Meeting is being recorded.
All the announcements. All righty. Good afternoon, everyone. Welcome to our session on treating patients where they are, innovative approaches to addiction in the ED. My name is Megan King. I use she, her pronouns, and I'm one of the organizers of this series. Before I turn the session over to our fantastic speaker, I have a few housekeeping items to go through. First, this session is being recorded, and we will make all recordings and slides available by early next week. You will click into this session just like you did today, and the recording and the slides will be there. In order to earn a certificate of attendance, you need to watch a minimum of 5 live or recorded sessions by September 15th. And as a reminder, we are not able to provide CEs or CEUs this year, just that certificate of attendance. So please ask your questions in the Q&A tab on the right-hand side of the screen. Dr. Roby will answer questions as they come. So just pop them in that tab as you think of them. And you can also introduce yourself and chat with your fellow attendees in the chat tab. So that is it for housekeeping. Now I get the pleasure of introducing you to our speaker, Dr. Roby. Dr. Roby is the medical director at the Snohomish County Diversion Center, and he works the overnight shift in the Providence Everett Emergency Department. He learned during his emergency medicine residency at Yale New Haven Hospital that every emergency department should offer buprenorphine. Close to 15 years later, he is here to share his insights on this and how we can better employ patient-centered treatments and peer support. So thank you so much, Dr. Roby, for lending us your expertise and insights today, and I will pass it off to you now.
Well, thank you very much, Megan. And for those of you joining from Dr. Comstock's talk in the clinical track, I'll be piggybacking on that and taking our conversation in the next logical direction of what it is we do in the emergency departments in the Puget Sound area to interface with patients in need of the next level of care for their addictions. And this comes from my my experience as an emergency physician and as a researcher at Providence and Everett, where we are looking to implement new techniques to treat addiction for patients who might not actually be seeking treatment. So as disclosure, I'm the local site PI for a NIDA funded study through the NIH in collaboration with ADAI at the University of Washington. I have been the local principal investigator for a separate NIDA grant to test a methamphetamine treatment, and I have received some of the Purdue Pharma settlement monies to implement some programs in our emergency department in Everett. So these are our topics today. We've already learned a little bit just in the last hour about Suboxone induction in the emergency department, and I'm not going to provide any more scientific background to the Suboxone induction than Dr. Comstock did, but maybe comment on the implementation of programs in community EDs. We're going to talk about some partnerships with peer navigators that are situated in the emergency department and how that might help us reach that segment of our population who use opioids and overdose on them. And excited to talk about some new methamphetamine treatment options that might be coming down the pike here in a few years. These are our objectives. I'll share these slides on the Whova app if you're interested in that, but let's get into the meat of what we're going to be talking about today. And just as Dr. Comstock pointed out, buprenorphine is often referred to as Suboxone. Suboxone is the combination drug of buprenorphine and naloxone. And any usage I have of the word Suboxone isn't an endorsement of that product, just a reference to what our patients refer to this medicine as. So opioid treatment has been a struggle for uh, many years in reaching enough patients to make an impact in their lives. It is very rare that I encounter a patient addicted to opioids who hasn't considered quitting or isn't in the process of trying to quit. However, the addiction can dominate both the social and the medical needs of these patients, which makes it hard to reach. And as many have pointed out, it's difficult to interface with treatment options that take into account the social and economic context of our patients, especially in larger urban emergency departments. And in the Puget Sound region, I'm speaking from some significant local experience, and in that we've been inducing patients on buprenorphine and giving a prescription for the last, I'd say, 5, in some cases, more than 5 years. And this relies on a good relationship between the emergency department and local providers. The concept of a bridge clinic is very important for patients who might be coming into the emergency department with opioid use disorder, in that we have to have a reliable location where a patient can go the next day or soon thereafter to continue the treatment that gets started in the emergency department. And it's sometimes difficult to find these community partners. And in our region, the company Ideal Option has stepped in as having been founded by emergency physicians as a place that says, yes, come on down. Now that Ideal Option has paved that way, we're seeing many more other local clinics, community health clinics, CMAR, these places, opening their doors to patients referred from the emergency department, holding open some appointment spots for these folks. And now in the age of the X waiver, it being the X partner of us giving buprenorphine in the ED, I think this is really transforming emergency department practice, and we'll see how that phases in with our fentanyl experience. So in general, when someone comes into the emergency department and is actually interested in starting buprenorphine or other opioid use disorder treatment, we use the clinical opioid withdrawal scale to assess whether someone is at a physiologic state where they can safely be given buprenorphine. And it used to be when it was oxycodone or heroin that some providers would give buprenorphine if the COWS was only 6 or 7. In fact, that foundational study out of Yale used 6 as the cutoff, and that was with mostly heroin users. But what we're seeing recently with fentanyl is that it would be it's much more likely that we might induce precipitated withdrawal in a patient with a COWS score less than 10, or who has used recently. And sometimes these half-lives of the fentanyl, because of its lipophilicity and predominance in the adipose tissue, can result in some induced withdrawal, even if they've used more than 24 hours in the past. So if the patient is dishonest, if perhaps they're exhibiting some shame, if they're maybe they misunderstood what constitutes a last use, these are folks who we might think about not starting buprenorphine in the ED now that fentanyl is our predominant opioid on the street. So what happens when precipitated withdrawal occurs? because it's now occurring more often in emergency departments that give buprenorphine. And generally the answer is give more buprenorphine and give it quickly. Don't wait. Try to get on the phone to the pharmacy to release the order. Let your nurse know that this isn't something that's going to go away in the next 10 or 15 minutes, and it's only going to get worse. And generally, the answer is if you've given 8, give 8 more or even more than that. Usually, in my experience, in our region, precipitated withdrawal can be adequately managed with 16 milligrams of buprenorphine, and the most I've ever given is 32 total. And this is essentially a cartoon schematic that explains how the buprenorphine might bump out heroin, or in this case, fentanyl. The pharmacokinetics is better accessed in Dr. Comstock's, who also very clearly addressed microdosing. And I'm just going to skip to the punchline for microdosing, except to welcome some of our maybe community track members here to say that the Bernese method or some of the other microdosing methods rely on a 3 to 10 day course of starting almost subclinical doses of buprenorphine, 0.5 milligrams once a day, that gets escalated to a twice a day dose and then stopped at a therapeutic dose. This doesn't need a washout period. It doesn't need people to be in withdrawal. It doesn't generally cause precipitated withdrawal. And in the end, it's difficult to administer in underhoused patients. It needs frequent follow-up visits. And in someone who has a difficulty following up, or maybe doesn't have the structure to get that follow-up, it's not going to be our go-to be-all, end-all for treating this. And so this is where the high dose all at once for someone who's interested in switching to medication-assisted therapy is going to be most useful. So at Providence, we've given probably about 400 doses since March 2019. And we refer folks to all of the local clinics and some of the private clinics as well. And we have a protocol where when a patient is started on buprenorphine, the docs can pick a preset order that will write their prescription for them as well. This way, patients who are new to prescribed Suboxone can be flagged and connected to a social worker, either in the emergency department or the next day in our behavioral health urgent care. And these are the types of supports that we've set up to essentially fill the role of a local bridge clinic in a community setting where there may not be the funding or resources to support providers in a true bridge clinic like what is sometimes available in larger or academic centers. So these are some of the seminal works on how to implement buprenorphine induction in the ED. Andrew Herring and Kate Hawk, along with Dr. D'Onofrio at Yale, have really put this out there as a way to really standardize care for folks who are sometimes in the more vulnerable category of our patients. Any questions about buprenorphine before I move on to some new approaches in connecting patients with peer navigators?
I'm not seeing any in the Q&A yet, but we can give folks a few seconds if they want to type anything out.
Again, a lot of this is becoming, and thankfully becoming, very, very standardized. And unfortunately, fentanyl has provided that fly in the ointment of making the dosing strategy a little bit more challenging. And so I think that makes it incumbent for those of us who are trying to shepherd our emergency department providers into providing this medicine. Um, we just have to keep them updated on the best treatment doses and strategies.
So Dr. Roby, we did just have one question come through. Have
Yeah.
you found that all of your emergency department physicians are on board with prescribing buprenorphine?
Great question. I started I really started pushing buprenorphine as a viable treatment option in early 2019. We got permission from the hospital to put it on the ED formulary and made the relationships with our local clinics so that we could get a good referral system in place before I started reaching out to the other docs in our group. And I would say that it took about 2 years to get everybody over the skepticism or the uncertainty that goes along with providing this medication that at the time had a lot of extra hoops to jump through in order to prescribe it. We were able to, of our group of 50 docs, I think about 14 ended up getting waivers before the waiver requirement was absolved. So they became kind of experts and resources and could write prescriptions for folks, even for patients of other docs who didn't have waivers, because we have a big department and there's a lot of double and triple and more than that coverage. And so that was the strategy that we took in our large emergency department. I would say, actually, I know how many of our docs dispensed Suboxone or buprenorphine in our department last year, and it 36 had written for buprenorphine. So we got there eventually, and there are still some physicians who are less comfortable with it, and mostly it just has to do with making it simple, providing the basic pharmacology and having folks get exposure to it as well. So if I'm there in the department, I'll help someone do an induction, and then they'll feel comfortable doing it in the future. That's a strategy that we've taken in our shop.
Thanks so much. I'm not seeing any additional questions.
Great. So peer counselors, I think, are the next wave in how we can better connect with our opioid using patients in emergency departments. And if you're familiar with the opioid using population and familiar with the emergency department, you'll realize that the Venn diagram of opioid users and opioid users who overdose, that overlap generates the individuals who are probably least receptive to receiving any referrals, treatment, or follow-up options of possibly all of your patients, not just opioid using patients. And the kind of flow that we see with these individuals is that a patient might overdose in the community. And it's been many years since I've actually given naloxone or given the first dose of naloxone in the emergency department, because it's so ubiquitous in our community, thankfully. So the naloxone is given in the field either intranasally, or if the medics arrive, IM or IV. The patient's revived. Sometimes withdrawal is precipitated, but in either case, we still advise medics to transport that patient to the emergency department. They come in by ambulance or in police custody, and then what we're presented with is identifying what the patient's motivation will be to stay in the emergency department. The emergency providers in the audience will, I'm sure, remember their last patient who eloped after being revived with naloxone or Narcan in the field. So in many cases, they may elope. They may try to get out of there as quickly as possible. They may say whatever you want them to say in order for them to be discharged, and then it repeats the cycle. So partnering with individuals who have lived experience with addiction is well accepted in treatment communities. And it's been logistically difficult to provide this kind of resource to patients while they're in the emergency department. So what is a peer counselor? Well, it varies from state to state. And in Washington state, we have a certification program that accepts individuals who have lived experience with addiction and who are in recovery. And I believe the requirement is they must have been in recovery for 2 years and have experience with some sort of treatment program. And the peer counselor is trained to provide peer-to-peer emotional and logistical support for individuals with addiction. And at Providence, we, up until recently, had a peer on staff in the hospital, which is unique. This is not this is a grant-funded role, because currently with Medicaid rules, peers are not reimbursable in inpatient medical settings, and that includes the emergency department. So around the country, there have been increasing successes with social work and medical treatments partnering with peer counseling, both in outpatient and inpatient settings. And what I've been privileged to be a part of is a NIH-funded study that is testing whether bringing a peer into the emergency department immediately upon that overdose patient arriving to the ED is beneficial for that person's survival. And so we enrolled any patient who had an overdose in the last 30 days, usually in the last several hours, who wasn't suicidal. We'd enroll in our study and either link these individuals with a peer or receive referrals, which is our treatment as usual, usually to our bridge clinic or our behavioral health urgent care. This state certified peer counselor then was assigned to work with a subject for 6 months, and with the goal of determining whether that reduced other overdoses, whether there were changes in harm reduction and improved outcomes from harm reduction behavior. And this was also a feasibility measurement. So could this be implemented in different emergency departments? Because it has been used in a few select academic EDs elsewhere in the country. So looking forward to why we're doing this, this is really testing what peer services in a hospital could look like, right? So let's say someone comes in who has overdosed or is just has opioid use disorder. The idea is that anyone in the ED team, a nurse, a social worker, anyone on staff, a doc, could find out if this patient would like peer support. That peer then could provide simultaneous support for this individual while they're in the waiting room, while they're waiting for treatment, help them understand why they might need to wait a couple of hours after an overdose to be released. And then also provide a real warm handoff in that transition to ongoing outpatient treatment, whether it's through peer support or other options. And maybe it's not feasible to have peers in-house all the time. It certainly wasn't for us. We had a sort of an on-call system that really only extended into the evenings, not 24/7. So maybe a peer referral might be a useful technique where you ask the patient, hey, we have someone who's struggled with addiction and is in recovery right now. Would you be interested in talking with them tomorrow? They could call you. And that could provide a way, again, to link these vulnerable patients to the treatment that might be best suited for that individual. And that's really where the peer comes in useful. Is that not everybody is going to benefit from buprenorphine. Not everybody likes methadone. Not everybody likes NA or AA, right? But there's a multitude of treatment options that are available, and connecting patients to that treatment option via a peer, we think can really help move things forward. So what we found so far is that patients are generally open to having a peer. Recently overdosed individuals sometimes are in denial, or perhaps just not ready to accept help from anyone. But we really hope that this can move forward our medical toolbox, provide a new way for us to connect these folks with the kind of treatments that might actually help. Not a lot of literature on putting peers in the emergency department. These are two articles. We hope to be able to expand this considerably with this study, which is still ongoing, and will complete in about 4 months. Any questions about peers? Any experience with peers you'd like to share, specifically in the ED, or questions about that?
I'm not seeing anything yet, but people, please.
Let me just say that the funding is going to be your biggest challenge, and that's what I'm working on right now, is trying to find maybe some grant funding opportunities that can support this relatively affordable intervention, given what we're seeing as the benefits in terms of ED recidivism and even beneficial outcomes from social services and law enforcement as well. This is a strategy that may be implementable at a county level or at a city level, in partnership with some of the community outreach teams that are increasingly being integrated into law enforcement. There's a lot of ways that that we could work with peers that overlap with the hospital, but also are in the community, in the setting where they already are being effectively used as extensions of the care team. Okay. Well, what can we do about meth? So methamphetamine is one of the drugs that we see co-ingested and co-used by many of our underhoused patients and many of our more vulnerable patients. And as we all know, there's very little pharmacologic treatment options for methamphetamine, especially when it's elevated to when its abuse pattern has elevated to addiction. And what I'm very excited to tell you about is a clinical trial that we were a part of last year that tested this novel agent called IXT-M200. Doesn't have a brand name quite yet, which has been invented by a company that's fully supported by the NIH, founded by some academics in Arkansas. And the two studies, if you want to look them up on clinicaltrials.gov, are METHOD and OUTLAST. And what this does is test what we did is tested a chimeric monoclonal antibody that binds to methamphetamine. And monoclonal antibodies have become commonly used in emergency departments now in the age of COVID as a frontline defense to provide immune support for the treatment of severe COVID infections. Well, this is an antibody that has been in development for decade, at least, that is very specific to amphetamines, including methamphetamine, and doesn't rely, unlike buprenorphine treatment, it doesn't rely on binding to any endogenous target. So it doesn't bind to receptors. All it binds to is the drug. And so in general, it only binds to these exogenous amphetamines. And it itself has relatively rapid on and off rates for methamphetamine binding, which means that this drug can work like a shuttle. And we'll get to that in just a minute. Okay, so the half-life in the bloodstream is about 20 days. And because it has these fast on, fast off properties, it can redistribute meth from the brain into the bloodstream. It doesn't permanently bind the meth, it just moves it away from the brain so that it can be processed by the liver and the kidney. And this juggling is the mechanism that we take advantage of to keep it from returning from the sites of action in the brain. So even though the half-life is 20 days, this antibody sticks around and is detectable for almost 5 months. So here's another schematic to try to strike home that mechanism. So what we have up here is a cartoon of the neurons in the brain. You see these yellow dots of methamphetamine binding to the postsynaptic membrane of the neuron, but the meth is also circulating in the blood. But when you implement this monoclonal antibody, the antibody binds to the meth, thereby moving the concentration of from the neurons into the circulation, and then transfers that meth to the kidney and the liver, where it can be processed. And then when there's no meth in the system, the antibodies are still there, such that if someone relapses, the antibodies are there poised, ready to bind that drug, with the principle that this could blunt some of the high that someone gets when they use methamphetamine. It doesn't eliminate it, but it blunts it such that we see folks not entering that downward spiral of amphetamine and stimulant use. So our early results, and we've concluded enrollment in this study, but we haven't finished all of the data analysis, is that patients who received the experimental agent made considerable strides in putting their lives together. So we're talking getting an ID, getting on a list, and even acquiring housing in the first 30 days after receiving this treatment. Some of our participants obtained employment. Many were enrolled in ongoing OUD treatment, usually with buprenorphine. People were making medical appointments. We saw strengthened relationships, and many of these participants came back into our 1-month visit with a significant other or with a parent supporting them. These patients who didn't receive the agent, however, just continued to experience the paranoia and disorganization that goes along with moderate meth use. So we're really excited about this agent and hope that it can get to market in a reasonable time. This is not expedited, meaning it's going through the FDA process in the sort of the standard timeline, which means there could be approval by 2026. Our contribution to this study shows that it appears to be safe in the emergency department setting, though it was very difficult to enroll folks you can imagine that finding the right patient who's high but not quite high enough to provide informed consent to receive a new agent that could affect their life for the next 30 to 60 days was a bit of a challenge, and that it might be best implemented in more of a clinic setting, but that this drug provided about the same amount of anxiolysis that a moderate dose of haloperidol or lorazepam provides to folks who come in affected by methamphetamine. So we're really excited about this being an agent that isn't going to be the end all for meth addiction, because really, if we could write prescriptions for housing and for stable relationships, then I think that would probably do better than this agent. But maybe this is a bridge to getting those things for our more vulnerable. Just a plug, doing research in the emergency department on with substance using patients is challenging, but provides a foundation for being able to provide some of the latest treatments for substance use disorder. And so I just want to thank all the people who I've worked with at Providence and beyond, who've been able to support expanding access to innovative treatments for this overlooked population of patients. Happy to answer any other questions, and you can always email me if you're curious about trying to implement some of these programs. Maybe I can learn from you as well. I think this format is fantastic about bridging different disciplines and making the lives of our patients better.
All right, we do have a couple questions that have come through. All right. Some of my fentanyl and meth users say they use meth to keep focused and organized. A deeper dive shows that they would meet the diagnostic criteria for adult ADHD. Pharmacologic treatment of ADHD redirects them to symptom management and halts their illicit street use of meth as self-ADHD treatment. Any experience with this from your perspective?
Yeah, absolutely. I mean, many of the best candidates for that particular study who were excluded were because they had concurrent ADHD diagnoses and had been prescribed one of the prescription stimulants to treat that. From the emergency department perspective, I would never begin to start an amphetamine treatment to treat amphetamine addiction. However, certainly from my understanding and from my study in this field, that is one approach in a controlled setting. The challenge is that the use of methamphetamine as a survival drug, either to organize themselves or even just to stay alert so that they're not beat up or have their stuff stolen, makes it difficult to balance that particular treatment. But yes, I support that approach, certainly, but just not in the emergency department.
Okay, we have a couple questions about the peer counselors. Is there a barrier to treatment providers sending peers to the hospital if they are willing?
So in order to get a peer in the door at the hospital, they have to probably be somehow credentialed at the hospital. So that's one of the challenges. That's one of the barriers. So so our peers were actually employees of the research department, but had clinical access to the EMR and all of the requisite training involved with having direct patient contact. And so I would say if there's a peer already in the community, getting them into the emergency department would require some sort of staff arrangement, even if it's unpaid, so that they would have a badge and a credential, so that providers would know who they are. However, if a patient already has a relationship with a peer, then that peer could be their guest or their friend or family member accompanying them to the emergency department. I wouldn't see a problem with that at all. But that would require the individual already accepting that person as their accompanying individual.
Great, thank you. And the next question is, can our own non-union staff become peer counselors and pay them as part of their regular FTE?
So becoming a peer counselor will oftentimes will rely on having a significant lived experience with substance use disorder, meaning generally that they have been users themselves, not just exposed to others who use. That might be a barrier for non-union staff at the hospital becoming peer counselors. There's no true barrier necessarily to become a peer counselor. You just have to enroll in there's a bit of a waiting period to enroll in the state certification course. But I could see the right individuals being peers. It's just figuring out how the hospital would pay them for their services. That would be the challenge, since the hospital isn't going to, in current situation, the hospital is not going to be reimbursed very much, if at all, for those individual services. Does that answer your question? Perhaps.
Feel free to type that in the
Bit of a
chat.
delay. Yeah. We can get back to that too if it doesn't.
We have about 15 minutes left, everyone, if you all have additional questions. I have a standard question that oh, wait, looks like there's oh, they said yes. Great.
Actually, there is ongoing lobbying. If any of you work with peers in your day-to-day work, every so often there are some bills that come up in Olympia that would include peer counseling in the reimbursement scheme for Medicaid in inpatient settings. And so there are efforts to move that forward, and currently nothing on the docket right now, but I'm sure there will be later in the year. So if you're interested in helping us with that effort, wouldn't mind testimony.
Excellent, thank you. We just have a standard question that we have been asking our presenters. So if folks only saw the title of your session, couldn't attend it, what is the one thing you would like them to know, or the one action you'd like them to take?
Yeah, so the challenge with treating diseases of substance use in the emergency department is that everyone has a different history and a different interface with those diseases, with those substances, and not every individual is going to benefit from every treatment. And in the ED, we have some treatments. We don't have all of the substance use disorder treatments that that someone might benefit from. And so I would challenge people who are healthcare providers or emergency department providers, if there are many on this call, to not be dissuaded by an inability to provide something right now. get familiar with your local resources, with the treatment programs, both inpatient and outpatient, what different programs like. Some programs want you to induce on Suboxone and some don't before you transfer, if they're eligible for a detox, for example. Um, uh, and and then also consider the polysubstance use patterns of your patients, and try to build your rapport with those individuals by prioritizing the substance that they might want to start working on first. And that is going, I think, to provide um, more um, benefit to these individuals than just applying a protocol, or having that extra 2-minute conversation to um, uh, to find out what it is that we can do to help right now. I think is what we need to have happen more in our emergency departments, um, because that might encourage folks to seek care in a different setting in the future when they need it. And so that would be my message for providers and clinicians, especially who are in an acute care setting. For folks who are in the community, which I believe will be a majority of individuals in this audience, I would say that every emergency department is different, and every emergency provider is different, and each emergency provider is different on different shifts, right? You're gonna get people in a different context if there's 100 people in the waiting room than if there's a lot more time to sit and talk with folks. And so I think that forming a relationship with a provider or two in your local emergency department could go a long way to helping your patients when they get into the emergency department. So if you can identify a champion, either someone who's kind of working with utilization or with uh, uh, solutions to homelessness, or someone who's kind of taken the lead on substance use treatment, try to find out who that person is in your community, and just talk with them and find out, hey, what do you guys do in the ED for this, for our patients? I'm trying to understand, when my patients in the community need to come into the emergency department, uh, 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 what do you have to offer them? Because I think the disconcerting truth is that the patients who we're referring to in many of our talks today, and the patients who we're thinking of when we're watching these talks and giving these talks, they are the folks who we don't connect with the most, and they're the individuals who might benefit just a little bit more from your just a better relationship between the emergency department and the community. And like many of the patients who come in who don't have substance use disorder, I can move them from where they are to where they want to be with not a lot of effort, okay? But I don't get them very far along that track, okay? But in patients who are dependent on multiple drugs and have a lot of health needs, just a little bit more time can get them so much closer to where they want to be than a patient who has a purely organic medical problem. That amount of time that we can provide in the emergency department for these underserved patients, I think it can go a long way. So reach out to your ED, find out who the chair or the medical director of the emergency department is, and just ask, hey, is there somebody who I could connect with to make sure that your docs know what the services are that we can provide in our community. So that's my pep talk. I knew I had a lot of extra time, so I made that one a little long-winded. So hope you didn't fall asleep.
Nope. And we did have, this is just a comment, not a question. Dr. Roby, I am in California. Our Medi-Cal waiver includes payment for peer counselors. Hopefully that will be the case for Washington now that you have your own approved waiver.
Yeah, so peer counseling, you know, there are several states, California being one, that we cite as, hey, come on. Other states are doing, come on, why can't we do it? And so it's just, there are personalities and other barriers in the legislature that I won't get into. But you know, with every new treatment comes the question, well, does it really work? And hopefully this trial will be part of that, and hopefully other people might be able to cite this trial when the data come out, because it's looking very good that having a peer available in the ED can really bridge that gap to harm reduction behavior.
And then just one other comment that's on here. Really appreciate your level of understanding and comments about the provider therapeutic relationship and pressures. Thanks.
Well, I'm not working a shift right now, so I can have all the time in the world to talk about that. It's a little different sometimes when you're in the thick of it. But you know, I think that with the X waiver going away, and with and I think buprenorphine becoming standard in the emergency department is really opening conversations about how we can treat our patients where they are and where they need to be. And so I think all of this conversation about the X waiver has at least brought this topic to the forefront. And whether or not buprenorphine needs to change in the age of fentanyl, that's still an open book. But at least we're talking about SUD more and more in the ED.
Well, I am not seeing any additional questions come through. Just one final comment, if for all those people who are watching right now, if you did not catch Dr. Comstock's session right before this on the scoop on bupe, hard to say, highly recommend that you watch that. It pairs very well with Dr. Roby's session. If you have any additional questions that you think of after the session ends, go ahead and put them in chat or in Q&A afterwards, and we can convey those to Dr. Roby. Dr. Roby, thank you so much for being here today. I know you have a very, very busy schedule and you just got back from vacation, so we really appreciate you spending your time with us.
Oh, it's a pleasure. Thank you so much for having me, and I look forward to the other talks in the conference.
Wonderful. Well, everyone will give you back 7 minutes. You can have a little bit of a break before our next session on naloxone. We'll see you all there. Bye, everyone.